Hello, everyone. Hope you can hear me loud and clear. We are back with Dr. Vladimiro Silva. How are you feeling,
Hi, Caroline. I'm
Vladimiro?
fine, thank you. I'm very happy to be here once again and to be able to share our experiences with you guys. And congratulations on bringing back this initiative of Stronger Together. I'm very happy to participate on this.
And we are indeed very happy to have you back. It's always great to have you back. So, thank you so much once again for joining us, as this is our second edition of Stronger Together. So, huge thanks for that. And of course, welcome everyone to our live event. And just let me start with saying that if some of you still don't know who Dr. Vladimiro Silva is, I just want to let you know that he's an embryologist, CEO, founder, and IVF Lab Director at Ferticentro. They have 2 locations. And please remind me, where exactly are you located?
In Coimbra, in Portugal.
Exactly. Perfect. Thank you so
Coimbra is
much.
in the center of Portugal, 1 hour from Porto, 1 hour and 45 minutes from Lisbon.
Wonderful. Thank you so much for that reminder. And of course, as you know, we will start off with Dr. Vladimiro's presentation. And our topic for today is learning from previous IVF failure and optimizing the process. So, of course, he will start off with his presentation, and afterwards it will be time for your questions. So, as always, all you need to do is just to type those questions in the chat section. You can do it during the presentation or later on, so that Dr. Vladimiro can help you out a bit. So don't hesitate and don't miss that chance and ask your questions. And of course, let me remind everyone that we are gathering here every single day to support you, to let you know some of the top experts, but also to give you that chance to ask your questions, to find out, to look for answers that possibly haven't been yet answered. So thank you for joining us over and over again as well. And also, I would like to thank our ambassadors and partners for their support. There are plenty of those ambassadors, as you can see, and it would be very difficult to simply create Stronger Together events without their assistance. So thanks a lot. And well, that is it from me at this point. And of course, we will start with the presentation. Dr. Vladimiro, ready?
Ready. So let's do it.
Perfect.
Well, hi everybody. Thanks for listening to me. Like Caroline was saying, my name is Vladimiro Silva. I'm the head of the IVF Lab at Ferticentro. We are a group of 2 clinics, Ferticentro in Coimbra and also Procrear in Porto. In Coimbra, we have the more international clinic, but we also work from Porto. Today's topic is very interesting and also very broad. When this wonderful person from myivfanswers.com, when they invited me to do this, I got well a little bit concerned because there was just so many things to talk about. So I'll try to summarize a few of the most important topics. This list isn't obviously exhaustive. And so I try to focus on the learning process, because when we start, when we deal with patients, sometimes we receive patients, and we being in international clinics, many often receive the patients at the end of the line. So most patients have already done a lot of treatments elsewhere. Sometimes they've also done some treatments with us, and we've had failures. Sometimes us, sometimes other clinics, and that happens. It's part of the process, and so this presentation will be about all of that. So, like I was saying, despite all pink scenarios that science paints, because we tend to focus on the good news, we all have to acknowledge that IVF does fail. And it fails a lot more often than we would expect. And the main reason for it to fail is because we as humans are not a very fertile species. I'll go over that question in a few moments. So, what happens when treatment fails? What can we do? Well, this is the take-home message from this presentation. We learn. We should optimize the process. We should use that failure as an opportunity to learn and to optimize treatments. The first thing that we need to do when we have an IVF failure is to take care of you, obviously, because you, whether you're a single lady, whether you're an heterosexual couple, or a couple of two women or two men in some countries, you need to take care of you. And so the first thing after a failure is to understand whether you're ready or not to move on, whether it makes sense to take a break, whether it's possible to take a break, whether is this affecting you personally or at your relationship. Obviously, in the case, not in the case of single women, but in case of couples, is this affecting their relationship, their marriage? Is this the time to listen to counseling, to share your experience with your peers, to listen to specialists, psychologists, fertility coaches, therapists? There are lots of persons very experienced in helping patients at this stage. And so, for example, yesterday there was Andrea Trigo here. She's wonderful at, in this kind of work. So my advice here is you don't forget the psychological part, don't forget the learning process, and let's move on only if we are ready, if you are ready. So obviously the physical and emotional balance is very important if we want to succeed while trying again. So the message is, take your time, don't be afraid to wait if necessary, but know your odds. Obviously, in IVF, we also have to acknowledge that sometimes we don't have time to wait, especially when we are dealing with the patient's own eggs after the age of 35. The clock starts ticking, and so sometimes we don't have that much time to wait, to think, to concentrate, to focus on more emotional subjects, and we just need to move on. Okay, so it's not very easy to do this kind of balance, but it is important not to lose track of this. People should think of themselves as well. So when you're ready to move on, that's time for medicine to take over the process. And the first thing that we need, especially if you are moving to a different clinic, is to know and evaluate everything that happened before. It's very important to get a hold of all the reports of previous treatments, previous tests, previous blood tests. A lot of patients get to our clinics without having a treatment report from their previous treatment. Sometimes they feel unhappy, obviously, when treatment fails and they throw everything away. I can understand why they do that, but at the same time, they are losing very important information. And we all like to benefit from other clinics and other doctors' previous experiences. So it's very important to keep all of that so we can have more direct evaluation. It's also important to pay attention to all signs and symptoms that could somehow seem noteworthy. Don't be afraid, even if you think the question is stupid, don't be afraid to ask it. We're here to assess that. We don't judge patients, and we always respect all questions are legitimate, and sometimes even the most simpler questions might raise important questions. So please don't be afraid to ask wherever you feel the need. So going a little bit on the topic, what are the causes of IVF failure? Obviously, there are a lot of possible causes. So let's start with the ladies, and we will go over all of these factors. Random factors, the lucky, sometimes this is just bad luck. Actually, most of the time when IVF fails, it's essentially bad luck. We also have gynaecological factors, endometrial receptiveness factors, genetics, immunitary factors, and hematological factors. And we're only taking a look at the ladies' side. Regarding the randomness and luck of the human reproduction process, like I was saying in the beginning, we all have to acknowledge that we humans are not a very fertile species. In this graph, you can see that it's sometimes maybe the violet line, the straight line, the violet line represents the human fertility. This is not an IVF related graphic, it's the fertility in humans. And we see that after the age of 35, I don't know if you can see my mouse here, but especially after the age of 35, fertility starts to decline and the miscarriage rate starts to rise, and it rises very steeply, especially after the age of 42, 44. So this is what nature gives us, and so that's what we have to work from. Okay, so obviously we would all love to say that IVF has 100% success, but it doesn't. Okay, we get 25% when we are on the top of our fertility, and then it only can go down. Okay, this is the human fertility rate. There's no way around this. And why does this happen? Well, one of the reasons is that because our embryos are not that good. For example, in these two graphics, you can see on the left-hand side a study, a genetical study done on more than 20,000 embryos, and the percentage of euploid, meaning normal embryos. And you can see that at the age of 34, 60% of the embryos were viable, but with the progression of age, the percentage of viable embryos drops significantly. The same thing on the right-hand side, you have a graphic that represents the likelihood, the probability of retrieving at least one viable embryo from an egg pickup. And so we start here at around 80% at the age of 35, and we end up in very low numbers with the progression of age. Obviously, you can also look at this in a different way. This is about the egg viability, and so we see that on the red line on the left-hand graphic, we have the live birth rate according to maternal age, and again, after the age of 33, 34, it starts to decline. The aneuploidy, meaning the rate of chromosomal abnormalities, starts to increase, especially after the age of 35, and obviously the probability of having a miscarriage goes the same way, also a little bit after the age of 36 or 35. And on the right-hand side, we can see that this is a very interesting graphic because this is the percentage of trisomy, and you can see that it increases with age, the colored graphic, and in the balloons we have the average age of the woman, the average women's age, the average female age at the birth of their first child. And we see that in the 70s, we were here at around 26 years, and now we are at around 30 years. And this is dangerous because we are approaching the limits where the risk of trisomy increases dramatically. And so when we are delaying, when women are delaying the decision to have a child, and obviously it's not an option, it's something that happens in their life. It can also be an option, obviously. This is the associated risk. And when we have trisomies, these are embryos that are less likely to implant. So this is where we get most of our negative results, and obviously most of the miscarriages. And when we talk about trisomy, we would have the same results for other genetical abnormalities. Trisomies are just some of the most known factors. For example, in the case of trisomy 21, the risk is 1 in every 1,064 cases at 10 weeks of pregnancy at the age of 25, and it goes to 1 in every 19 at the age of 45. So this is a very huge increase in risk. And so when we start going a little bit on the same table, on the same graphic that we saw in the beginning, let's start discussing the possible, so randomness was the first one. It is associated with women female age, with a lack of quality of the eggs, the age-related the age-related decline in egg quality. The second group of factors are the gynecological factors. So when we are trying to have a baby and when we have an implantation failure or an IVF failure, we have to take a look at the uterus. There are different ways to look into the uterus. We can look into the morphology of the uterus or into the functionality of the uterus. On the morphology level, we have the fibroids or myomas, we have malformations, we have adenomyosis, we have synechia, we have hyperplasia. I mean, there are things that can affect the morphology, the shape of the uterus. And then we also have factors that affect uterine functionality, like, for example, endometritis or adenomyosis. Just to explain fibroids, fibroids and uterine malformations, like, for example, septum. So those are things that make changes to the morphology, to the form of the uterus. Hyperplasia, for example, is the case of polyps. Well, the function of the uterus is more compromised by infections that can cause endometritis or adenomyosis, that are parts of the uterus where we don't have the growth of the endometrium. How do we evaluate this? By doing ultrasound scans, hysteroscopy, sometimes even MRIs. It's important to understand. So one of the first steps while evaluating a previous IVF failure is to understand whether we have good uterine conditions for implantation. And so we resort to all of these tests. The fact that you had a previous scan or a previous hysteroscopy or a previous MRI that showed nothing relevant is not necessarily a sign that things couldn't have changed in the meantime. So we really have to take a look at that. Another important step is to check for endometrial receptiveness. We know that when we transfer an embryo to an endometrium after 5 days of progesterone, that endometrium should be prepared to receive a day 5 embryo, meaning a blastocyst. So we do a preparation, an endometrial preparation with estrogens. Then when we have an endometrial thickness of at least 8 millimeters. Here it says 6, but we always prefer to have at least 8 millimeters. There are other studies that show a better prognosis. There are, however, patients where we can't get more than 6. We have to confirm that we don't have the interference of natural hormones, in this case, natural progesterone, and then we start giving the patient the progesterone. The progesterone will turn the endometrium, which is on the proliferative stage, into the secretory phase. And that's where the endometrium starts to get more vascularized and more ready to receive the embryo and form a network of blood vessels that will nourish the embryo and allow for its implantation. However, in some cases, after 5 days of progesterone, some women are not yet ready to receive an embryo, a 5-day embryo, or on the other hand, they are already post-receptive, meaning that their endometrium is already starting a degeneration process. How do we assess that? So we do an endometrial preparation like the one that we do in the frozen embryo transfer or an egg donation cycle. And on the day of the embryo transfer, instead of doing the biopsy, we take a little piece of the endometrium and we analyze 248 genes. And then the result would be one of 3 possibilities: pre-receptive endometrium, receptive endometrium, which is the ideal, or post-receptive endometrium. And in this particular case, the ERA test, we get an information stating something like this endometrium is not receptive at 120 hours, but it will be at 144, because they have developed an algorithm that allows them to predict when would that endometrium become receptive. Okay, according to studies published by Igenomics, which is the lab that created this test, 3 in every 10 patients with recurrent implantation failure are found to be non-receptive when tested for endometrial receptiveness. And also, on the other hand, when they started to compare patients where these tests have been done with patients where no tests have been done, there are significant increases not only in pregnancy rates, but also the percentage of miscarriage rate, the miscarriage rate drops. And so, and when they look into cumulative rates, they found out that 70% of women gave birth after a year. And this is a population of women with at least three implantation failures. So it's a very good result in a group of poor prognosis patients. One other thing that we can think about is genetics. And in this case, PGTA. PGTA is the acronym for pre-implantation genetic testing for aneuploidies. What is this? Aneuploidies are numeric chromosomal abnormalities. Okay, so when you have your embryo has the wrong number of chromosomes. Normally what we do is we create the embryos in the lab, we take them to day 5 or day 6 to the blastocyst stage, and then we make a little hole in the embryo and we go and aspirate a few cells, normally around 5 cells. Those cells are then sent to the genetics lab. They are analyzed by a technique called NGS, Next Generation Sequencing, and we will see whether the embryo is viable or not. You can see on these graphics, these are very interesting graphics, because on the gray bars on the left-hand graphic, you will see that the implantation rate for patients who have done PGTA is relatively steady with the evolution of female age. I'm sorry because the graphic is a little bit too small, but it's more or less between 50 and 60% for all age groups. While on the orange bars, we can see that we start around 50% and then the percentage lowers. The orange bars correspond to IVF without PGTA. So the orange bars are sort of the natural pregnancy results, where you can see that with the progression of age, the number of viable the number of embryos that implant is lowering. It gets to more or less 7% after the age of 42, where the rates stay very high when we do PGTA. It is very important to stress that PGTA doesn't improve the quality of the embryos. It just gives us more information about the embryo quality. And so the reason why here we have 50 or 60% instead of 7 or 8% is because we are transferring a selected population of embryos. We're only transferring viable embryos, genetically viable embryos. Still, we are 40% far from 100%. So there are other factors that can that can keep these embryos from implanting. This can be related to the endometrium. This can be related to the other factors that I've talked about. So gynaecological factors, immunitary factors, hematological factors. There are lots of immunitary factors. There are lots of possible explanations for these failures that are not genetics. So transferring a genetically correct embryo is a good step forward to make sure to increase the probability of having a positive result. However, it will not affect the embryo's likelihood to implant, because the embryo is still the same whether we test it for chromosomal abnormalities or not. It is also important to see that this decline in natural pregnancy rates only starts after the age of 35. So before the age of 35, or using donor eggs, it makes little sense to do this PGTA, because statistically speaking, we would get more or less the same percentage of pregnancy with or without it. So it's a respectable decision to do it before the age of 35, but it will certainly, it's very unlikely that it will affect the probability of pregnancy. On the other two graphics, we can see the same cases in terms of delivery rates, so already accounting with the miscarriage rates, and obviously the miscarriage rates themselves that increase significantly with the cases with age, especially when we're not doing PGTA, because those correspond to the chromosomically abnormal embryos that we are transferring for these patients, because we obviously don't know whether they are normal or not. One of the possible solutions that we can use in these cases is to do what we call the egg banking. So sometimes we stimulate the ovaries of a patient, we collect their eggs, we freeze those eggs, we start a new stimulation, we try to accumulate even more eggs, and when we have a good and nice number of eggs, we move on with egg fertilization and embryo creation, and then the PGTA if necessary. That's a way of optimizing the process. Sometimes we advise patients to target a certain number of eggs. Ideally, if we have 15 eggs, it would be great. If not, 10 eggs or 8 or 10 eggs is already a nice number. We can still do this even with just one egg. It's just a question of probability. We know that the more eggs we get, the more likely we are to have nice embryos. So this is one of the possibilities that we discuss with patients, especially when we try to optimize the process after a previous IVF failure. Sometimes we receive patients that have negative results and we don't know why. Sometimes patients have a past history of 8 embryo transfers, and in reality we don't know, because none of those embryos were tested for genetic abnormalities. And so we can't really tell what was happening, whether it was the embryos that were not good, whether it is the endometrium. So when we have a certain number of IVF failure, it's advisable to test the embryos chromosomically. And when we have low numbers of embryos, because the woman is not producing anymore, and in order to test a good number of embryos, a good solution would be to do egg banking. This way we would be optimizing the process. Okay, so another group of factors which is rather complex, I will not bother you too much with this, are the immunitary factors. There's a lot of discussion going on the KIR HLA-C factors. Well, I'll try to explain it very quickly. At the uterine level, there are cells that are called the NK cells, the natural killer cells, that have receptors that bind to the embryo paternal origin HLA-C molecules. It's sort of the natural defense of the female body against an external entity. Each person, each man, each woman has its own profile, its own KIR and HLA-C profile. And there are lots of possible combinations. It's a little bit explained in this article. I will not go over it, but there is one single combination. It's the combination between the profile, what we call the haplotype, KIR AA, with the male HLA-C2 that is associated with a strong inhibition, and so a poor reproductive prognosis and a higher obstetric risk. We have to pay. This is still. This is relatively recent. Some studies are being done on this subject. There are ways to treat this. If we have these factors, we have special protocols for these patients. If we're working with egg donation, for example, we can try to get a donor who is not a carrier for some of these factors. Again, this is relatively recent. There are a lot. We still need more studies on this subject. These theories are doing their first steps, but in reality, those kind of investigations are more dedicated to patients with at least 3 previous implantation failures, and the same for the endometrial receptivity tests. Okay, another immunitary factors that we hear a lot are the immunitary activity at the endometrium level. There's this lab in France, it's called the Matrice Lab. There is this doctor, Dr. Lédé. She's very known, especially in the French-speaking world, with lots of patients doing this kind of tests, and they are doing a very nice work as well. So their test is based on the dialogue that occurs between the endometrium and the embryo. Okay, we know that the endometrium and the embryo, they have to connect in many levels in order to make the implantation, and obviously at the endometrium level there are several phases, the proliferative phase, the luteal phase, and where I'm sorry, where different cells and agents are being produced. I will not go over a lot of details, and so this is again this focuses again on the natural killer cells, and so in this Matrice Lab test they do 3 kinds of evaluations. They evaluate the histologically the endometrium, so in order to know that at the tissue level it has developed correctly. They count the number of natural killer cells to see if it is correct, if it is low, or if it is high, and they also assess the cytokine expression, which are molecules that participate in these immunitary rejection processes. And so they split patients in 3 groups: underactivated endometrium, overactivated endometrium, and normal endometrium, which is not listed here. And so there are specific therapies for every group of patients. And so again, this is a test that we recommend for patients that have at least had 3 implantation failures. Once again, this is based in a lot of theories. Some more studies are needed to be for us to be completely sure of the effectiveness of these therapies. This Matrice Lab test is a very interesting one. We recommend this test a lot to our patients, like we do with the ERA test, not so much with the KIR test. And there are obviously other immunitary factors at the systemic level. These are just some examples, because if you have an autoimmune disease, it will affect your probability of having a baby. Different diseases have different profiles. There are lots of very rare and expensive tests that can be used. These are just examples of tests that we request in the routine when we have repeated implantation failure cases. Another group of factors that we should consider are the hematological factors. And so we search, there are thrombophilia panels available that can give us a risk of having a thrombophilia problem. Thrombophilia are a group of diseases that are related with the ability of the blood vessels to connect to the embryo and create that necessary network of vessels, and thus to trigger the implantation process. some people, some women and men, obviously, are born with some genetic variants, let's call some genetic variants that are associated with a higher thrombophilia risk. This is not sort of a non-off situation, so the pattern of variants present in many genes are associated is associated with a global risk that then should be assessed by an hematologist. So this is sort of a screening to identify the patients that are at risk to have an hematological thrombophilia problem, and then it's up to the hematologist to tell whether it makes sense to do further testing or not, and then there are therapies that we can use in those cases. Okay, so for all of these situations that we're looking for, there are alternatives. If we have problems in the gynecological side, we can do surgeries, or we can do corrections or antibiotics. Obviously, in the case of adenomyosis, unfortunately, there's nothing we can do. On the other cases, where we have endometrial receptiveness, receptivity issues, immunitary issues, hematological factors, there are therapies that can be used and should be developed and adapted in function of each individual case. Okay, that's something that we need to address on a patient basis. There is obviously, when we're talking about previous IVF failure, where does the problem come from? Is it the egg or the sperm? Even if we're resourcing to donor sperm, donors are humans, okay? Their sperm can also have abnormalities. And a few years ago, there was this very interesting study published in one of the main scientific publications in the IVF field, where they concluded, they were postulating that aneuploidy and maternal age studies show that overall the X contribution is greater than the sperm contribution and could be estimated in about 70 or 80%. Okay, the sperm being responsible for 10 to 15% of the process, and the uterus for another 10 to 15%. Obviously, we know that when the paternal component is abnormal, it can drastically affect the ability of an embryo to reach the blastocyst stage, or a fetus to develop and result in a live birth. Okay, so sometimes even when we have embryos evolving in the lab, and we see that systematically we have a development problem between day 3 and day 5, we suspect of the male factor. Not that there couldn't be female factors that can cause problems in making a blastocyst, but the male factor, the likelihood of finding a male factor increases in those cases. And so, what about men? Let's talk a little bit about men. One of the things that we hear all the time is that male fertility is declining. So, is it really declining? Well, it all started with this study published in 1992 on the British Medical Journal from a group of researchers from Denmark, where they concluded that after reviewing the results of sperm counts since the 1930s and until the 90s, there was a net decline, a clear decline in the number, in the total number of spermatozoa. And especially, and even when they did the analysis by groups of men, in green there are the men with more sperm, with more than 100 million per milliliter. In those, so the groups of men with more spermatozoa were declining. The groups of men with less spermatozoa were increasing. This study has a lot of impact, especially on the media. But then there were some other studies concluding, reaching to different conclusions. For example, in the United States, in the Seattle area, they concluded that there is no major change over the years in sperm quality. that it was more associated with geographical factors and probably environmental exposure to different age, to different conditions and temperature and even lifestyle. There was another study in 2001 which was very interesting, where they were comparing the number of the quality of the sperm in groups of men in different European towns during winter and during summer. And it was very interesting to see that during winter, sperm was better in all countries. Okay, in Finland, they won this kind of competition. They had 132 millions, while, for example, in Copenhagen, there were only 98 millions. But in all cases, winter was better than the summer. Okay, this is a curiosity, but in fact, all of these geographical and season variations point is to differences in environmental exposures, temperature, for example, and obviously temperature, pollution, lifestyle, and obviously there could be some degree of genetic and ethnical influences on this. And obviously, we men all have our ups and downs, because this is a very interesting study that was published on the laboratory manual for the examination of human semen, published by the World Health Organization. And they, in this study, 5 men were producing sperm samples every few days, and so and for a year and a half. And so they were registering the evolution of their sperm parameters through time. And we see that there are huge variations in many cases, with men ranging from brilliant values to almost to infertility situations. Obviously, this all depends on what happens in the personal life of these men, whether they are having intercourse or not, whether they are drinking, smoking, sleeping well, not sleeping at all. We really don't know what's happening in the life of these volunteers, but we can see that the same man can produce completely different samples. Okay, so this is also something that we need to evaluate while reviewing a case of previous IVF failure. And so what can we do in the lab when we have this? Well, we have to imitate nature. And in this graphic, you can see that I will not go over many details on this, but we can see that when we are taking care of male causes of infertility, we can resource to the techniques that correspond to the part of the process that is not happening in nature. So in nature, we know that the sperm goes from the spermatogenesis, the formation of the spermatozoa, into the fertilization smoothly. When we have a problem on the female tract, for example, on the cervix, or a small number of a small but not too small number of spermatozoa, we can use an intrauterine insemination, or, for example, if we just need to overcome, or if it's a single lady who needs a sperm donor, we can also, the intrauterine insemination is the first line approach. Obviously, if the problem is more serious, if it involves the female tract, if we have a low ovarian reserve and we need to make sure that fertilization really occurs, and we can go to IVF or even ICSI, especially if we have low numbers of spermatozoa. In our case, we use ICSI also when we have low numbers of eggs, in order to optimize the fertilization process. This is not consensual. A lot of clinics don't agree with that. This is, however, our internal policy. And also, if the problem on the male side is more serious, we can even do surgical sperm removal, and where we go directly to the testes and collect the sperm from there. So, but in the case of male fertility, there's sort of an irony. We're mostly not treating male infertility. We have to acknowledge that. we're helping infertile men to become parents. Okay, this is, however, the second best option. It would be preferable to treat the patients so they can have their kids naturally. Unfortunately, there are very few cases where that's possible. I will not go over this on this presentation, but I mean, their goal is to have a kid, and so that we usually can, as long as we have the spermatozoa, obviously. So the bottom line here, and also an important take-home message, is that men should live a an healthy lifestyle. But however, sometimes there's little we can do. Okay, we can use those techniques to get the sperm, but there are not many treatments to optimize sperm quality, and obviously we have to forget that sometimes it's not very important. For example, Keith Richards has 3 kids and 5 grandchildren, and he is the opposite of someone with an healthy lifestyle. And when we are talking about optimizing the process and learning from previous IVF failures, in this case is more about optimizing the process, we shouldn't forget that we always have the last but also the most effective resource, which is egg donation. Okay, sometimes it's impossible. Sometimes chances are very little with using the women's own eggs, and so egg donation is always an option. It's never a first-line option, but sometimes it's the only real option or the only possible option at all. Egg donation, the first reason to use egg donation is because it works. Okay, these are the results from the United States, where we can see that for all age groups, pregnancy rates with egg donation are between 60 and 70%, and this is the green line on top, and on the blue line on top, and in the green line at the bottom, we see the natural pregnancy of cases with their own eggs, and we can see that egg donation always performs better when compared to treatments with own eggs. So these are the results from thousands and thousands of cycles performed in the United States in 2017, but these are the same all over the world. Everybody in the world is getting the same results because, again, it's human nature. It's human biology. There's no way to go around it. Sorry, these results are from 2015. So there's no way to go around human biology. If we're getting different results, that's because we are selecting patients, because this is what nature gives us. Egg donation. It's, like I said, a very effective method, but it has to be done in a very ethical and patient-friendly way. Like I was saying, non-anonymous donors are way preferable to anonymous donors, because by using non-anonymous donors, we respect every child's right to know their origins. Also, by using non-anonymous donors, we are controlling and increasing the chances of the children that are born from donations to get access on information of their biological parents, about their biological parents. This could be very important for health issues. Even in some countries with anonymous donations, those records exist, but it's not the same, because if the donor is non-anonymous, the donor knows that she can be contacted in the future. She agrees with that. She will not be contacted without knowing that it could happen. Okay, so egg donation should also be done in a very transparent way, in a limited way. We don't want donors donate. We don't want our kids to send their DNA to a DNA database 20 years from now and get the response that they have 20 or 30 half brothers and half siblings. This is why in Portugal every donor cannot donate more than 4 times in her lifetime. We are one of the few countries where there is a central control by the state on the limit of donations. The access to the identity of the donor is granted by the National IVF Authority, and again, all donors are counseled and are informed about the possibility of being contacted later in life by children born from their donation. Obviously, egg donation should be affordable, should be accessible. It shouldn't have waiting lists, and especially I'd like to focus once again on the anonymity of the donor, because nowadays with the genetic databases, there is another presentation on this topic that I've made a few months ago. There is no such thing as an anonymous donors. And so by choosing an anonymous or a non-anonymous donor, we're just choosing whether the donor will be found by accident or in a controlled and well-counseled way. It is possible, it is like this nowadays. It will certainly be easier to find the identity of the donors 20 years from now. So donors are never anonymous. What changes is the way that we access that information, or how easy it is to get that information. And so it would be it. This is it. Thank you for listening to me. I'm available to reply to your questions. This is a picture of our team. You can, if you want more information about us, you can go to our website. You can also write me an email. I try to reply everybody. These days we are a little overwhelmed with so many requests, but I'll try to answer all emails and questions.
And wonderful. Thank you so much for yet another great presentation with lots of details indeed, but definitely useful. And well, as you can see, plenty of questions are right here as well. So are you ready for them?
Let's go. Let's go.
All right. Okay, let me start with this first one, which is a bit of a longer one, okay? Let's have a look. So thank you, Doctor. The presentation is very informative. I am 38, AMH is 1.6 with hypothyroidism and insulin resistance. Both conditions have been treated and my T4 and insulin levels have been in the normal range for about 5 months. I completed an IVF cycle in August. I had 6 eggs retrieved, all fertilized, but my embryos either atrophied, not sure here, sorry, or were abnormal. My doctor concluded that it was bad luck, and he is optimistic that a second cycle will have a positive outcome. What are the odds of a second cycle succeeding after a first cycle failed due to egg quality? Also, is there any sense in pursuing a UI after a failed IVF cycle? And thank you for the question.
Okay, thank you, Stephanie, for sharing your story with us. So I will start from the last question. It doesn't make any sense to try intrauterine insemination in this case, because, I mean, if the tubes are patent, so if we don't have a problem, any blockage at the tube level, intrauterine insemination is cheaper and it's less invasive. However, the odds of an IUI to work at the age of 38 are between 7 and 8%. So this patient, she had this problem of insulin resistance, hypothyroidism, and she actually has a nice ovarian reserve with a nice AMH. So I would say that the odds seem okay. The age is a little bit over the 35 threshold, but we have lots and lots of patients doing IVF and getting babies at this age, and even at ages a lot later than that. So I would say 6 eggs doesn't seem like a lot, but my advice here would be to try again. Obviously, try to optimize the ovarian stimulation process. I didn't talk very much about that part, but there are different protocols that we can use. Sometimes a protocol works better than the other. Sometimes we can try different strategies for different patients, and we get even the same patient responds differently to different strategies. So I would say that I agree. I don't know if it was bad luck. I don't know if there's also a male side problem, but I think we can, with an AMH of 1.6 at the age of 38, we can hope to get more than 6 eggs. And if we really want to increase chances, we can do what I was mentioning, do the egg banking. If we really can't get more than 6 eggs, we can try to do 1, 2, maybe 3 stimulations to get a good number of eggs, and then fertilize them all. Do the PGTA if that's legally possible, and see whether the embryos are viable or not. Okay.
And there's a thank you from Stephanie right here for
Thank
you.
you, Stephanie. Good luck for your treatment.
Of course. Good luck. Best of luck indeed. Okay, let's have a look. Next question is also right here. We have done 3 ICSI cycles, and due to low AMH 4.2, I only seem to produce 4-6 follicles, of which have only had 1 embryoblastocyst each time, which failed to implant. Is there any point doing PGTA with only one blastocyst, and is there risk of PGTA damage? Sorry, cannot say that today. The blastocyst.
Okay, so first of all, just to explain the other patients, probably the units of Belinda's AMH are different than the units of Stephanie's AMH. If Belinda is indicating her AMH in picomole per liter, it is equivalent to 0.53 in the same scale as Stephanie. Okay, so in fact, this is not a very high AMH. If it is really 0.53, if it's 4.2, it would be great. If it is 4.2 nanograms per milliliter. This is a technicality, but with the story that the patient tells, I'm assuming that we're talking about picomoles. So it is a low AMH, bottom line. She has done 3 cycles. She produces 4 to 6 follicles, which is not a lot, and she only has picomole per liter, and she's confirming it, Belinda. So, like I was saying, she's only getting 1 embryo each time. The point of doing PGTA in a case such as this, well, first of all, I don't think the PGTA will damage the blastocyst. Okay, that's a risk that always exists. It probably affects like 2% of all blastocysts. If it's done by an experienced technician, by an experienced biologist, by someone who does it on a daily basis, and that's what it's a very delicate technique that requires a lot of experience. So if you're doing this, you should be doing it in a clinic that does a lot of these procedures, whose embryologists are certified to do this technique. Because, for example, I will give the example of Ferticentro. We had to certify all embryologists before starting to do PGTA on our own. So we did hundreds of procedures in mouse embryos and embryos that were offered to scientific investigation before started doing it in real cases years ago. So again, if we only have 1 blastocyst, I think the interest of doing PGTA is sort of, because the problem with Belinda is that she has done 3 cycles and she doesn't know why is it failing. Okay, so is it the endometrium? Is it the embryo? She doesn't know, and so maybe her embryos were good, and the problem is on the uterus side. So PGTA will give her the information on, will help her to decide in the future whether it makes sense to try again with her own eggs, to think about egg donation or not. If some patients, they just don't want egg donation, they say it's either with my eggs or I don't want to try. If that's the case of Belinda, I would say she shouldn't do PGTA. Okay, if she is thinking about it and what is the best decision. Okay, but again, it goes the same way. Probably we have factors from both sides. So, like I was saying, if for Belinda egg donation is not a possibility, I wouldn't advise her to do PGTA because it's preferable to let nature decide, do the embryo transfer, and see what happens. If she needs to make a decision after a possible new IVF failure, I would definitely advise PGTA, because if the embryo is viable, then before transferring the embryo, she would have time to study the endometrium, all of those factors that I've talked about in my presentation, and so before transferring the embryos, we would have the possibility to optimize the conditions of implantation. If the embryo is not viable, then it would be pointless, and probably the most likely reason for the previous failures was already the genetic part of the embryos. We would never know. We can only postulate or speculate on that, but I think PGTA is about information and is about helping patients making decisions. So I would probably advise PGTA unless the patient says that egg donation is not a possibility. Good luck. Hope everything goes well with you.
Exactly. Thank you so much. And let's have a look, of course, at the next question that we have right here. So just a second. It's here. I am 40. AMH is 1.69 nanograms. At trigger day, my E2 was 2085. How many mature eggs should I expect with this value? Does it also tell about the quality? After egg retrieval, I was told some of my eggs were destroyed, and they mention my age. I didn't really understand. Could eggs just get destroyed after retrieval?
Well, starting from the beginning, AMH of 1.62 at the age of 40 is actually a nice value, okay? With an estradiol of 2000, we would expect to normally we expect to have one egg for every 300 units of 300 picograms per milliliter of estradiol. So in this case, we would probably expect to have 6 or 7 mature oocytes. No, unfortunately, this tells us nothing about the quality. Obviously, if we have, for example, 6 eggs with 2000 picograms per milliliter, it's in line, okay? If we have, so it's always, when we have a correspondence between the hormonal levels and the number of eggs, that's usually a good sign, and it's a good prognosis sign. However, the true response on the egg quality, we will only get it either from the genetic testing or from the embryo quality that we obtain in the lab. So this question about eggs being destroyed, sometimes, and we do have those cases as well, when we have especially in advanced women, in advanced stage patients, some of the eggs are very fragile and they degenerate when we start manipulating them, for example, to do an ICSI. we have to, I mean, without looking at the case, I cannot give you an opinion, but usually when they start to degenerate, this means that those eggs were not viable. Okay, sometimes the eggs, especially in advanced, in female age cases, the female advanced age cases, the eggs are very fragile and they degenerate very easily. So those eggs are not viable. They would never originate a pregnancy in a natural conception. So those are sometimes in some cases we only have eggs like that. Some other patients we have a few eggs like that and a few normal ones. It's really hard to tell. Okay, again, this has to do also with the lab conditions. We have to, I mean, we would need to have more information to be able to give a fair opinion.
And again, thank you so much for explaining that. Yes. And actually, there is another part of history from Belinda, okay? So let me just show you some more here. Unfortunately, okay, even with highest menopause dosing 450, it didn't respond as expected. Only one follicle grew when previously I had 4-6. So consultant decided we should do IUI instead of wasting it. Although that wasn't our original plan, we had to make this decision. So strange why I didn't respond like before. If this IUI were not to work, of course we pray it does. We intend to retry embryo banking again. What's your opinion for my poor response, and do you think it's good to try again and treat the previous attempt as priming my ovaries, as my left ovary was quiet apparently?
Okay, so starting from the beginning. So 450 units of menopur a day is a lot. In theoretical terms, above 300, we will not get a better response. Usually at our clinic, we use 375 just to be a little bit over the theoretical limit of 300. Some doctors try 450. That's a respectable decision. It's not only about the menopause, we also have to think of the rest of the protocol. We also, whether it was a long protocol or a short protocol, and in the case of short protocol, there are different types. We at Ferticentro, we don't like to convert to intrauterine insemination. We prefer, even if we just have one follicle, we try and we prefer to do the egg pickup. It's our policy because we do have pregnancies with just one egg being collected, just one embryo. And so we prefer to do it instead of the IUI because the ICSI method is a lot more effective. But again, this is a common practice, okay? It's just our opinion. It's a respectable opinion from the other doctors. So a lot of clinics worldwide are doing this. We just feel that it's preferable to collect the egg. I mean, it's all about optimizing the process because clearly Belinda she wants to get pregnant with her own eggs and instead of moving to egg donation, and so if she only has one, we would try to use that one egg as good as possible. Okay. Also, I do agree with what the patient states at the end of this. So there are evidence that say that repeated attempts, especially consecutive attempts, tend to optimize the ovarian response. And so, yes, this previous attempt could have worked as a priming for her ovaries, and a subsequent new stimulation, especially in the 3 months after this previous one, will certainly have a better response from the ovaries. Okay, sometimes it's hard to predict whether this will really make a difference or not, but I do think it's worth trying. I mean, regarding if we're only getting one egg after an aggressive stimulation, we can also think of changing the protocol, but maybe they already tried that. And so, but in principle, it would be an indication to try with egg donation.
Thank you so much. And yes, as you can see, there is an answer from Belinda.
Well, again, good luck, Belinda. Happy to help you.
All right. Thank you so much once more. Okay, let's have a look, of course, at the next question that we have right here. So what what number of mature eggs does a 40-year-old need to get a blastocyst? What percentage of eggs, M1 or M2, survive after freezing?
Well, several questions in the same. We don't know, okay? How many eggs do we need to get a blastocyst? In theory, one could be enough. On average, for example, at our clinic for older women, we can have a blastocyst rate of 40, maybe 45%. It really depends, obviously, also on the male side. So I think this was the patient with poor egg quality that we were discussing before. So maybe 30% of the blastocysts of the eggs will turn into blastocysts. It's hard to tell like this. What percentage of eggs survive after freezing? At Ferticentro, we have more or less 90% of survival for egg vitrification. We don't vitrify M1 metaphase 1 eggs. We only freeze metaphase 2 eggs. On the other hand, I don't see any reason why the metaphase 1 wouldn't survive vitrification. So I would say it's 90%.
And thank you so much once again for that. All right, let's have a look. Of course, there are plenty more questions coming up. And another question from Margie. Does a dose of FSH of 300 UI differ from result to a dose of 325? Is this dose too high?
It's the maximum dosage. Theoretically speaking, above 300 international units, all the receptors are already occupied. All the FSH receptors on the ovaries are already occupied, and so it's pointless to increase after that. Like I said, sometimes we go a little beyond, because some patients could be outliers and they might respond a little better to 375. We've tried higher dosages, we haven't seen a difference, so this is why we usually don't go over 375. So 325 is a little higher. I would say that under the assumption of that I was making, it could make sense. And based on what Margie has told us in her previous messages, I wouldn't say it is too high for a case such as hers. But again, we know nothing about her specific case.
All right, excellent. Thank you so much. And actually, sorry, there's one more from Margie. Is a low dose of FSH often better number of mature eggs than a high dose?
That's actually a little hard. Those are different treatment strategies. We also do mild stimulation IVF. Theoretically, there are, in some cases, there's a theory that it's preferable to try to get one good quality egg instead of many bad quality ones. It's never a first-line approach, because most studies indicate that when the more eggs we get, the better results we have until a certain level. Actually, even more recent studies are saying that there is no upper limit on the number of eggs, on the association between the number of eggs and the odds of pregnancy. But for quite a long time, we thought it would be the ideal would be between 8 and 15. Obviously, when we're not getting good quality eggs and we're getting a good number of eggs, we sometimes resource to mild stimulation IVF. In those cases, we give the minimum medication necessary, and we try to go in a very controlled and balanced way, just one follicle, hoping that it will work better than the other ones. A few years ago, more or less 10 years ago, we did a lot of these cycles at Ferticentro. Results were actually nice, but like I said, this is not a first-line approach. This is something that we use for patients that have a past history of poor embryo quality. These days we are focusing more on testing the embryos, but again, this is something that we can also do, obviously.
Okay, excellent. Thank you so much for that. Okay, and then one more right here. Could a sperm donor be a known person, family member in Portugal?
No, the Portuguese law states that donors are not anonymous in the sense that at the age of 18, the children born from the donations have the right of access to the identity of the donor. That access is granted by the Portuguese IVF Authority, the CNPMA, but this means that the donor is anonymous for everybody but the children. This is a right of the children, not a right of the parents. And so if it was a known person, we would be disclosing the identity of the donor before the children reaches the age of 18. So it's not possible to do what we call a direct donation.
All right, thank you for the clarification to this one. And of course, there are like 3 questions left, so we will be finishing. So if you have any questions left, go ahead and type those in, or remember, you can always get in touch with Dr. Vladimiro and his team, and I'm sure they will be more than happy to help you out with some more details as well. And the question is there a maximum follicle size allowed at egg retrieval for viable eggs? Could eggs become over mature?
Yes, eggs, sometimes follicles can grow too big. Typically, we trigger the ovulation when we have follicles at 17 millimeters. Often we have a mixed population of big follicles and follicles that are smaller, and so we try to bet on the population that gives us a better probability of finding a better quality and a better number of eggs. There are some other more recent strategies of dual stimulation, but those are still we're still living the early days of those strategies. But so ideally, we're talking about 17 millimeters. Above a certain diameter, I cannot tell you whether it's 20 or 21 or so, but above a certain limit, the risk of the eggs starting to degenerate obviously increases. There's this optimal moment to trigger the ovulation, and that's certainly between 17, 18, 19 millimeters.
All right. Excellent. Once more, thank you so much for that. And actually, you answered in regards to the sperm donor, if it's possible for a sperm donor to be known, like a family member. How about egg donor? If you could clarify that one for us as well.
It's the same. So
Exactly.
we can only disclose the identity of the donor once the children born from a donation reach the age of 18. Yeah, this is the same as lots of European countries have the same kind of legislation. Portugal, the UK, the Portuguese law is pretty much the same as the British law. Ireland as well, the Netherlands, Denmark has a mixed system, Sweden, Austria. There are lots of countries where donations are not anonymous, and I think in 10 years from now, all countries will have non-anonymous donations. The anonymous donations, it doesn't make sense from in the day in the actual times, it makes little sense. Not for the children, not for the families, not for the donors, obviously, and so I think it will end soon, hopefully.
All right. Thank you so much for that. Next question is, what is the cost of IVF with female egg donor in Portugal?
I have to tell our clinic's costs. We have essentially we have many programs. Okay, so it's a rather complex question, but to make it simple, it will depend on the guarantees. We have a 2 blastocyst guarantee program that costs 6,440 euros, and we have a 5 blastocyst guarantee program that costs 10,840 euros. The difference is that in the lab we always do the same. We don't have first category donors or second category donors. All of our donors have been subject to a very complete selection process. The difference between these programs are on the obligations of the clinic. If we only get 3 blastocysts and the patient has hired a 5 blastocyst guarantee, she's entitled to have as many cycles as necessary to achieve the 5 blastocysts. Okay, on average we have 4 or 5 blastocysts, but obviously we're dealing with human cells, so a lot can happen, and so this is why we focus our guarantees not in the number of eggs, but on the result of on the number of good prognosis embryos. If those blastocysts are not good prognosis embryos, we will not use them. Answering again, cost is about 6,400 euros. It could climb up to 10,800 if you want to have more guarantees. We also have programs with if you don't have a baby, you get all your money back, but those are more expensive. They cost 15,000 euros. We work with a British company called Access Fertility on that.
Wonderful. Thank you so much for that clarification. In the meantime, one more question is right here, so I guess we can have a look at it. What's the minimum follicle size for retrieval?
Okay. The minimum follicle size, normally it's 17 millimeters.
Okay, wonderful. Okay. Thank you so much for that answer.
Very quick and direct.
Yes, of course. Then that's perfectly fine. And of course, as I mentioned, we will be finishing. So if you have any more questions, remember that you can always get in touch with Dr. Vladimiro right here with this link I have just sent to you. That is an option for you to get some more answers. And of course, I'm sure they will be more than happy to help. Sorry. In the meantime, there's one more question I guess we can still answer, right? So it's a short one. My weight is 65. Would lose weight improve my results?
I don't know how tall is Margie, but we always tell patients that they should have a normal BMI. Okay, so we have to calculate the BMI. If it's between 1.60 m, well, let's make the calculation. I think this corresponds to a normal BMI. I actually don't have a BMI calculator in front of me, but I can take a quick look. So 160 for 65, just, well, I don't have, so just a moment and I will give her the answer. 160, 65, okay. It's 25.4. She's on the limit, okay, Margie. If you could lose like 2 or 3 kilograms, it would certainly help. However, you don't have it's not exaggerated, okay? I don't think BMI of 25 is a reason for IVF failure. It's not an explanation. Ideally, it should be below 25. So I would say that it wouldn't hurt to lose 2, 3, 4 kilograms, but it's unlikely that this is the explanation for the IVF failure.
All right, thank you so much for providing that as well. And of course, there's a thank you from Margie. And there are some comments for you right here. Thank you so much. You have been very helpful. And there's another one. My favorite doctor. Thank you once more for your great webinars. Just had my baby girl 5 months ago, but for another baby, I will run directly to Ferticentro. Good to hear that, and congrats
Yeah.
for sure.
Well, she's so nice. Thank you, Beata. Really nice to read this kind of comments.
Yes, of course. Thank you so much for that. We definitely appreciate it, and we are very happy to hear that your baby girl is already 5 months, right? So
Yeah,
thank
it's
you so
great.
much for that. Okay, and of course, everyone, thank you so much for all of your questions. And Dr. Vladimir, it's always great to have you here. So I know it's not our last webinar with you. Looking forward to the next one for sure. And well, is there anything else you would like to add?
No, just I mean, wish good luck to everyone, to Margie, to Belinda, to Stephanie, I think, the lady that asked the first question. And so it's really a pleasure to be here, to be able to discuss these subjects with you, Caroline. And it's obviously always a pleasure to participate in this kind of initiatives. And if you need anything else, you can send me an email. Like I said, I reply to everyone. Sometimes it takes a little longer, but I always try to answer all questions and messages.
No doubt here. So thank you so much. And of course, remember, this has been recorded. It will be available on our website, myivfenses.com, and of course, our YouTube channel as well. So you can go ahead and subscribe. That way you will know when the video is uploaded. And of course, if you go to our website, you will be able to find some other webinars with Dr. Vladimiro and of course some other experts, lots of them, as you know. So you can go ahead and visit our website to check it. And well, we will be back here, not tomorrow. However, we will be back on Monday at 8 p.m. UK time. So if you haven't registered yet for our next webinar, just go ahead and do it. I definitely hope to see you all here back. And well, have a wonderful evening or day. I'm not sure if you are all in Europe. So wherever you are, have a lovely day or evening. And Dr. Vladimiro, till our next webinar.
See you, Caroline. Thank you once
See
again.
you.
Have a
Thank
good
you so
night.
much. Thank
Bye
you.
bye then.
Bye.
Cheers. Bye bye.